This program is brought to you by Emory University.
Our speaker this morning is Maya Dassanayake. Maya is a first-year clinical fellow, for those of you that haven't met her yet. Maya came to us from the University of Michigan, where she did her residency, did her medical school at Wayne State, and undergraduate also at the University of Michigan. So left the frozen north to venture to Atlanta to do a fellowship with us. And as you can see on the screen, she's going to talk to us today about spontaneous coronary artery dissection. Maya.
Thank you for the intro, Dr. Williams, and thanks everyone for joining me this morning. Today I'll be talking about spontaneous coronary artery dissection, or SCAD. So I have no disclosures, and my learning objectives today are to discuss a case of coronary artery dissection, review the pathophysiology and current classification system for SCAD, and then describe our acute and long-term management strategies. So I'll start with a case, and this is the case of a 47-year-old lady who developed sudden onset left-sided chest pain after picking up her 15-month-old daughter. She described her chest pain as 7 out of 10 in severity, associated with nausea and lightheadedness, and had endorsed a prior history of rheumatoid arthritis treated with Plaquenil, as well as gestational diabetes with her most recent pregnancy. She has no family history of any cardiac disease, no history of any autoimmune disorders in the family, aside from rheumatoid arthritis in her mother, and no history of any vascular diseases. She had not been using any alcohol, tobacco, or drugs. She works as an 8th grade math teacher and had 2 kids, her 10-year-old and her 15-month-old. On exam, she was afebrile, hypertensive at 178/91, heart rate in the 80s, respiratory rate of 17, and setting in the 90s on room air. Her exam was really notable for her appearing quite uncomfortable due to her chest pain, but otherwise her lungs were clear, she was euvolemic, and no extra heart sounds on exam. In terms of her labs are notable for normal renal function with a creatinine of 0.8. She was slightly anemic with a hemoglobin of 11, normal LFTs, a negative troponin, and unremarkable inflammatory markers. Notably, her LDL was 83 and her A1C was 5.4. As you can see from her chest X-ray, she appears to have a normal cardiac silhouette and no evidence of any pulmonary edema or infiltrates on her chest X-ray. She also had a CT-PE done that was negative for PE. And on her presenting EKG, largely non-ischemic, and her troponin was 0.04. So at this point, I think we can talk about a differential for young women presenting with chest pain. And although atherosclerosis remains on the differential, we also have to think about things like vasospasm, Minoca, endothelial dysfunction, and overall having a low threshold for diagnosing SCAD in young women without the traditional risk factors for atherosclerosis. Several hours later, her subsequent EKG showed T-wave inversions in V2 and T-wave flattening in V3 through V6. Her troponin started to rise from 0.4 to 0.52. At this point, a heparin drip was started. She was aspirin and Plavix loaded and given 80 of Atorva and 25 of Metope BID. And at this point, she had an echo. And as you can see from this parasternal long axis view, her EF, you can still see from here, but her EF is mildly reduced, and she does have some hypokinesis of her anteroseptal wall. In the short axis view, you can also appreciate her mildly reduced EF and septal hypokinesis. And then in this apical 4-chamber view, I think you can best appreciate her reduced EF as well as apical and anterolateral wall hypokinesis here. In the subcostal view, you can see, again, reduced EF with lateral and septal wall hypokinesis. And overall, her echo was read to have this mildly reduced EF of 40–45%, with the entire apex and mid and apical anterior septum being hypokinetic. An EKG several hours after that echo started to show deepening T-wave inversions, and her troponin continued to rise to 2.1, and then eventually peaked at 2.3. While she was waiting transfer from the ER to the floor, she was noted to have frequent PVCs and runs of non-sustained VTAC on telemetry. And at this point, she was continuing to have chest pain despite several doses of sublingual nitro. Initially, based on her initial presentation, a left heart cath was deferred in favor of coronary CTA, but given her now electrical instability and ongoing chest pain, a left heart cath was obtained. And as you can see from her cath films here, her circ appears normal, but if you look at her LAD, she does have this haziness in the mid LAD, as well as some multiple radiolucent lumens here. And you can better appreciate that on the next film here. Where you can see this haziness in the mid LAD and these multiple radiolucent lumens extending down to the distal LAD here. And her RCA also appeared patent, much like the circ. So her films were read as a normal left main, some mid 50% haziness in the LAD with what appeared to be the start of a coronary dissection with involvement of her diag, and evidence of dissection from the mid LAD to the distal apical LAD with up to 99% stenosis in that distal portion with TIMI 2 flow. As I mentioned, her circ and RCA appeared normal. Her LVEDP was elevated at 27. So after her cath, she was sent to the CCU, put on a nitro drip, and continued on heparin and DAPT. And a summary of her CCU course really was notable for recurrent episodes of chest pain, nausea, vomiting, and going on and off of a nitro drip as her antianginals were up titrated. Eventually, her chest pain resolved on 50 of metope BID, 60 of IMDR, and the addition of ranolazine. And eventually she was taken off the nitro drip. Her repeat echo was notable for improvement in her EF to 60-65% and mid-anteroseptal hypokinesis. At this point, she was transferred to the floor and discharged after spending about a week and a half in the hospital. In follow-up, she was seen in clinic and continued to report some intermittent mild chest discomfort. Her antianginals were up titrated in the outpatient setting, and she noted some improvement of her post-SCAD chest pain. About 6 months after her index presentation, she was carrying her 2-year-old at this point and had a recurrent episode of chest pain, this time described as less severe than her initial event, but still reminiscent of it. And at this point, she was admitted to the CDU, and this was the point where I became involved in her care and saw her with Dr. Laleko, who had also been following her as an outpatient. Given overall low suspicion for a recurrent SCAD event, just given her negative troponins, non-ischemic EKGs on multiple EKGs, and a repeat echo with normal EF and no wall motion abnormalities, the suspicion for recurrent SCAD was low enough that we obtained a coronary CTA rather than repeating coronary angiography in her. And her CCTA did not reveal any new dissection. So her antianginals were up titrated with improvement in her symptoms, and she was discharged home with plan for outpatient follow-up. And as you'll see from the rest of this presentation, her case was not uncommon, as many patients suffer from post-SCAD chest pain from months to even years after their index presentation. And before we go into the pathophysiology and management of SCAD, I want to go back to the first suspected description of SCAD in the literature that I found interesting. So this was actually an article published in the British Medical Journal in 1931. And here the physician describes the case of a 42-year-old woman who had reported upper abdominal pain, nausea, and vomiting, to whom he attributed her symptoms to bad fish and chips from the night before. He had recommended bowel rest and castor oil, and unfortunately she died several hours later. At this time, he had performed an autopsy that actually revealed a dissection of her RCA and some blood in her pericardium as well. While this case was published back in 1931, there's still clearly a lot we have to learn about SCAD, but I'm going to go through some of the data we have now. So in terms of the prevalence of SCAD, it really makes up anywhere from 1 to 4% of ACS cases. And it does make up to 35% of MIs in women under the age of 50. It's the most common cause of pregnancy-associated MI in about 43% of these cases. And the average age of women with SCAD are ages 45 to 53 years. In terms of the pathophysiology, spontaneous separation of coronary artery wall by intramural hemorrhage is how we describe a SCAD event. And it's non-traumatic, and the key is it's also non-iatrogenic. So again, spontaneous separation of coronary artery wall from this using this intramural hemorrhage. It can be associated with underlying arteriopathies, and we'll talk about some of these associated conditions a little bit later, but the key is having this hematoma that develops within the tunica media, separating the intima or intimal medial complex from the underlying vessel. And this intramural hemorrhage is actually what causes compression of the true lumen, and compression of the true lumen results in coronary obstruction and ischemia. There's a few different hypotheses for how this occurs. There's an inside-out hypothesis where we start with an intimal tear and blood enters the subintimal space from the true lumen after development of this intimal disruption or flap. And blood enters and generates a false lumen. Alternatively, there's an outside-in hypothesis where we see a hematoma arising de novo in the media, possibly from disruption of traversing microvascular vessels in the vasa vasorum within the vessel wall itself. And interestingly, greater than 50% of patients actually recall a precipitating factor prior to their SCAD event. So some of these include intense exercise, intense Valsalva maneuvers, emotional stress, or use of exogenous hormones, or infertility treatments. But in terms of precipitating stressors, there was in one prospective study of SCAD patients from Vancouver, they found that 50% of patients reported preceding emotional turmoil prior to the event, about 30% cited physical stressors, and about 10% reported heavy isometric activities, such as lifting greater than 50 pounds. In terms of the clinical presentation, as you can imagine, the majority of patients present with chest pain, and several have additional symptoms such as radiation to the arm, nausea, radiation to the neck, diaphoresis, or dyspnea. Fortunately, only about 7% of these cases present with ventricular arrhythmias, and anywhere from 2 to 5% can present with cardiogenic shock. In terms of diagnostic tools, coronary angiography remains the standard for diagnosing SCAD. However, there is an intrinsic risk of iatrogenic catheter-induced dissection that is increased in these patients. So that risk is reported as less than 0.2 for standard left heart caths, but that risk is increased to about 3% in patients with SCAD. And the thought is that the underlying arterial fragility in SCAD patients is actually what accentuates this risk. Now we also have tools such as IVUS or OCT, where we can use intracoronary imaging in subtle or more non-diagnostic cases of SCAD. IVUS actually offers high spatial resolution to image the coronary artery wall and detect the intimal tear, false lumens, or intramural hematoma. And OCT has an even higher spatial resolution and is actually preferred over IVUS in helping to make a diagnosis of SCAD in these more subtle cases. So interestingly, coronary CTA can also be used in usually more of a follow-up context. So because of the lower spatial and temporal resolution, it isn't necessarily recommended for an index SCAD event with a high suspicion of SCAD. However, it can be useful for non-invasive follow-up, especially in proximal or large caliber vessels. And as you can see on this image on the left, this actually is a comparison of coronary CTA findings in a patient to their coronary angiography films. And you can see on the top here, this is actually, this white box is around basically a SCAD lesion in the mid-LAD, and comparing that to how you visualize the lesion on left heart cath. This bottom panel here shows several months later healing of the SCAD lesion on coronary CTA, and then comparing that to repeat angiography. And we'll talk a bit more about the healing of SCAD lesions shortly. Before going into that, I did want to talk about the ways we classify SCAD. So currently we talk about either type 1, 2, or type 3 SCAD. And for type 1, this is categorized as multiple radiolucent lumens or arterial wall contrast staining. And if you recall the cath films from our patient earlier, she actually did have this appearance of multiple radiolucent lumens in her LAD. And so she would be classified likely as a type 1 lesion. And looking at these additional images, you can see here a dissection of the LAD with an intimal flap starting from the proximal segment and extending to the distal segment. And here again shows a dissection flap in the LAD on the right here. And these are also examples of those multiple radiolucent lumens that categorize these lesions as type 1 SCAD events. In terms of type 2, these are more described as a diffuse smooth stenosis of varying severity and length, usually greater than 20 millimeters. Type 2 SCAD is actually more common. It is makes up to 67% of patients presenting with SCAD, and type 1 is the second most common, making up 30%, followed by type 3 at 3%. So here in this image on the left, you can see a dissection flap of the proximal LAD. And on this image on the right, you can see a long dissection flap in the mid LAD, making up greater than 20 millimeters. Type 2 can also be subclassified further into 2A and 2B. So 2A describes diffuse arterial narrowing bordered by normal segments, both proximal and distal to the area of intramural hemorrhage. So as you can see here on the left, type 2A shows this recrudescence of a normal caliber distal vessel here. And then type 2B shows an extension of the stenosis to the distal end of the vessel here. Type 3 lesions are actually the more challenging SCAD lesions to diagnose. So this is because these lesions can actually mimic atherosclerosis. The reason they mimic atherosclerosis is because they tend to look more focal or tubular and are less than 20 millimeter in length. So you can see here on the right, this is actually a compression of the left main in a type 3 SCAD event. And more recently, there have also been descriptions of total occlusions of distal vessels as type 4 lesions. So this is just an addition to our prior classification system. There have also been cases of multivessel SCAD. This actually makes up anywhere from 9 to 23% of cases. And these two images are showing multivessel SCAD affecting two branches, both the LAD and the diag. And this was actually also consistent with the case I presented earlier. In terms of the distribution of subtypes, the most commonly affected coronary is the LAD, making up anywhere from 32% to 46% of cases. Next are the CIRC, RAMUS, and OM, followed by the RCA. Unfortunately, left main SCAD events only make up about 4% of these cases. Mostly the mid and distal coronaries are affected, but less than 10% of cases can also involve the proximal LAD, proximal CIRC, or proximal RCA. For the acute management of SCAD, I like this algorithm because it actually breaks down how we think about these patients as either clinically stable patients without high-risk anatomy or clinically stable patients with high-risk anatomy versus patients who continue to have ongoing ischemia or hemodynamic instability. So for this first category of patients who are clinically stable without high-risk anatomy, really conservative therapy is what is recommended for this group. So in an observational study of 131 SCAD patients who underwent repeat coronary angiography, they noted spontaneous healing in about 88% of cases who had repeat angiography within 30 days of their index event. And anywhere from actually 97% to 99% of patients actually showed healing of these lesions in angiography performed greater than 35 days from the index event. So really, because of this high rate of the high rate and expectation of healing of the lesions, if we can manage these patients conservatively, that is the preferred strategy. And as early reinfarction can actually occur in anywhere from 6 to 17% of patients, this is why we actually recommend prolonged in-hospital monitoring for these patients as well. It's really to observe for early dissection extension or new recurrent SCAD. And unfortunately, at this point, there aren't really many angiographic or clinical predictors for who will develop extension of their dissection within 7 days of an acute episode. So this is all the more reason for prolonged inpatient monitoring of these patients. And in terms of the patients with clinical stability, but still with high-risk anatomy, these are patients who conservative therapy may be more challenging to pursue. And these are patients who we would have to think about pursuing aggressive management like PCI or even CABG. And I'll go through some of the data on PCI and CABG in a moment. But in terms of our medical management for conservative therapy, so the recommendations for heparin and DAPT are actually controversial currently. So even though in theory they may reduce thrombus burden, there is also this theoretical risk of bleeding given that the pathophysiology is based on intramural hematoma formation. One agent that we do have good data to recommend are beta blockers. So in a series of 327 patients from Vancouver with a median follow-up of 3 years, beta blockers were found to be associated with a reduction in recurrent SCAD by almost 2/3. And the same study actually showed that patients with underlying hypertension had an almost twofold risk of recurrent SCAD. So this really suggested that blood pressure control and use of beta blockers may be important tools in reducing our risk of recurrence. Other antianginals for post-SCAD chest pain syndromes like long-acting nitrates and calcium channel blockers are also an important part of therapy, but doesn't necessarily have an impact on outcomes. In terms of statins, they are not actually routinely recommended for SCAD. There was some initial data suggesting potentially increased risk of recurrence with statins, but more recently, we haven't actually seen any impact on statin therapy for reducing rates of recurrence in SCAD. So right now, it's primarily recommended for primary prevention of atherosclerosis, but should not be used independently for SCAD itself. In terms of ACE inhibitors and ARBs, those should be used for those with MI complicated by LV dysfunction, as we would for all patients, but really there's no data to suggest that those should be used for SCAD with preserved LV function. I mentioned earlier the risks with PCI. So diagnostic left heart cath, as I said earlier, is recommended, but PCI can be associated with higher complication rates and sometimes suboptimal outcomes. So this is because the affected coronaries are more susceptible to iatrogenic dissections and extension of those dissections with PCI. And guide wires can actually enter the false lumens and occlude the true lumen, causing worsening ischemia. So this panel actually shows an example of false lumen propagation during stenting. You can see on the left-hand side here, this This panel A shows a type 2A dissection affecting a high OM, but with maintained distal flow here. And then in panel B, you can see this is actually where the stent is being placed. But then in panel C here, you see proximal hematoma migration, and 2 further stents were actually required in this case to fully exclude the hematoma from luminal restriction. And as the dissection lengths in these patients are often extensive, they may require long stents, which can be associated with increased risk of in-stent restenosis or stent thrombosis. And ultimately, as the intramural hemorrhage resorbs over time, as we mentioned, we expect to see healing of these lesions. But the resorption of the intramural hemorrhage may actually result in subacute and late stent strut malapposition, which could also predispose to the risk of future stent thrombosis. In terms of the role of CABG, so during long-term follow-up, one study actually reported a very high rate of both venous and arterial conduit failure in 11 of 20 patients who underwent follow-up angiography. This is really almost certainly because of the healing of these native SCAD vessels and having competitive flow through the native coronaries that can actually promote graft occlusion. So this study also showed that CABG was not protective against recurrent SCAD events. In terms of post-SCAD chest pain, many patients may actually experience nitrate responsive chest pain either at rest or with mental stress, but may not have inducible ischemia with exercise. As I mentioned earlier, these patients may benefit from long-acting nitrates or calcium channel blockers, but treatment sometimes not only includes uptitration of those antianginals, but also paying attention to screening for post-MI depression and anxiety, as these comorbid conditions are unfortunately quite common in patients suffering from post-SCAD chest pain. So if the clinical suspicion and testing don't suggest recurrent SCAD, then there may be a role for SSRIs and even reassurance being an important aspect of treatment. Fortunately, another part of reassuring these patients can also include just informing them that the frequency and severity of these symptoms are expected to decrease over time. So this algorithm was noted in one of the consensus documents published in JACC last year on SCAD, and specifically focuses on the management of chest pain after a SCAD event. So of course, in the case of new or acute ACS, that would prompt appropriate evaluation with EKG, troponins, and imaging as necessary. But in the cases of stable, typical, or exertional angina, should defer to pursuing stress testing. And if stress testing is normal and patients are presenting with atypical symptoms, again, really focusing on medical management and evaluating non-cardiac causes, as I mentioned previously. So this was data published by a group in Vancouver, and it was a small sample of 18 patients, but these patients underwent coronary reactivity testing 3 months post-SCAD. And among those with chronic chest pain, greater than 70% actually had coronary microvascular dysfunction as measured by abnormal coronary flow reserve, and also with abnormal findings on their invasive coronary reactivity testing. So this really suggested microvascular dysfunction in both SCAD and non-SCAD arteries. And I found this interesting because there may actually be a lot of overlap between microvascular dysfunction and post-SCAD chest pain that we don't quite understand yet. Another important aspect of post-SCAD care is cardiac rehab. As with all cases of ACS, cardiac rehab is really important in continuing to follow up on patients who've had an ACS event. So in cases of patients with SCAD, they often have a hard time resuming a prior baseline level of physical activity, particularly if there was a preceding physical stressor before the index SCAD event. So cardiac rehab is particularly important in helping to establish blood pressure goals, heart rate goals, and helping return to baseline activity using free weights for resistance, and really emphasizing low resistance and high repetition so that patients are avoiding strain or Valsalva maneuvers that may precipitate recurrent SCAD. So in terms of associated conditions, SCAD is not commonly associated with systemic inflammatory disorders, but certain autoimmune or rheumatologic diseases may be predisposing factors in the development of SCAD in a small proportion of patients. Really, the biggest associated condition is fibromuscular dysplasia, and this can be found in up to 80% of SCAD patients. Additional associated conditions we'll talk about in a little bit, the association with pregnancy and multiparity. And there have also been cases linked to exogenous hormone use. So OCPs and hormone replacement therapies are also, use of these medications are things that patients would need to be counseled on after a SCAD event. So fibromuscular dysplasia, it's a non-inflammatory, non-atherosclerotic disorder characterized by arterial stenosis of small to medium-sized vessels. It's also characterized by frequent aneurysms, tortuosity, and dissections. And the classic term we hear about are the string of beads pattern on angiography or imaging. And most commonly, you see this in the renal arteries, but you can also have intracranial abnormalities. So because of the really high rates of concurrent FMD in these patients, vascular imaging from brain to pelvis is recommended for all patients diagnosed with SCAD. In terms of genetic evaluation for connective tissue diseases and erotopathies like Marfan's, Louis-Dietz, or Ehlers-Danlos, these genetic evaluation can be considered if a family history is present, but really that only makes up about 5 to 9% of SCAD cases. So it's not currently recommended that patients undergo any sort of genetic testing for any of these diseases. So most cases of SCAD actually have been linked to an association with sex hormones. And as I mentioned, there's clearly a strong female predominance, but even in terms of pregnancy and postpartum, 1.81 SCAD events per 100,000 pregnancies have occurred during pregnancy or in the 6-week postpartum period. Gestational hypertension and preeclampsia have also been variably associated. And as I mentioned, there are also other potential hormone-mediated triggers such as perimenopause, use of OCPs, and HRT. Interestingly, post-SCAD chest pain can actually also occur in a catamenial pattern. So this also sort of supports the association between SCAD and sex hormones. Unfortunately, in terms of pregnancy-associated SCAD, it has been associated with worse outcomes for patients. So this was a series of 23 women with SCAD, and the postpartum patients were actually found to have larger infarcts, more proximal artery dissections, and lower mean EF. Actually, those patients with proximal artery dissections, that was about 86% of pregnancy-associated SCAD and 19% of non-pregnancy-associated SCAD. In this Mayo registry of about 54 women with pregnancy-associated SCAD, these women were younger and less likely to have concurrent FMD, but the pregnancy-associated SCAD patients were also more likely to present with STEMI, have a lower mean EF at SCAD diagnosis, with more frequent findings of an EF of less than 35%. Those with pregnancy-associated SCAD were also more likely to experience SCAD affecting the left main or multivessel dissections. Interestingly, patients with pregnancy-associated SCAD were also further characterized as more likely to be multiparous with a history of fertility treatment or preeclampsia than those patients with non-pregnancy-associated SCAD. So you can see from this Kaplan-Meier from that same cohort, the estimated 5 years of recurrence actually look no different between SCAD during or shortly following pregnancy. And this actually argues for, so saying that there's no difference in rates of recurrence between pregnancy-associated SCAD and non-pregnancy-associated SCAD may make an argument against our prior recommendations that were that patients who've had a SCAD event should avoid pregnancy in the future. And you can see here from this, basically this was recent observational data published by a group in Mayo, where They showed recurrent SCAD with repeat pregnancy, again, suggested similar rates of recurrence in patients with pregnancy-associated and non-pregnancy associated SCAD. And of the 636 women in this cohort, 3% had pregnancy after SCAD. If recurrent SCAD was defined as occurring at any time after the initial SCAD event, about 19% had a recurrence. If defining recurrent SCAD was restricted to occurring at least a month after, then about 15% had a recurrence. But overall, their Cox analysis, when controlling for age at first SCAD and FMD status, it showed no significant association between subsequent pregnancy and SCAD recurrence. So you can see here, this was actually all non-significant hazard ratios here for both definitions of recurrence. So as the recurrence rate for SCAD isn't trivial and pregnancy is a known risk factor, traditionally, as I mentioned, patients have been counseled to avoid pregnancy, but I think the data from these recent studies suggests that we may need to reevaluate this recommendation. In terms of other management for patients with pregnancy-associated SCAD events, really there aren't a lot of recommendations, but the ones that we have are that for recommending patients to remain in left lateral decubitus after 20 weeks of gestation, for continuous fetal monitoring in those who are greater than 23 weeks having an acute SCAD episode. And I guess if delivery cannot be postponed into the late third trimester, really to focus on multidisciplinary management with maternal fetal medicine and cardiac obstetrics, and as well as OB anesthesia. So in conclusion, SCAD is clearly an important cause of ACS in young and middle-aged individuals, particularly women without traditional cardiovascular risk factors. And heightened clinical suspicion for it is an important aspect of accurate diagnosis and treatment. So most of our data on SCAD that I reviewed are retrospective and observational. So our knowledge is quite limited, but what we do know is that besides being diagnostically challenging, the acute management should include aspirin, beta blockers, prolonged inpatient monitoring, and reserving PCI for high-risk patients. In terms of our long-term management, focusing on beta blockers and other anti-anginals for post-SCAD chest pain, blood pressure management, screening for FMD, pregnancy and HRT counseling, and cardiac rehab. As I mentioned, so further research is of course needed on the topic, but we're actually a SCAD center here at Emory, so part of the National Registry of SCAD Patients called iSCAD, funded by the SCAD Alliance. So we're actually one of 15 sites that participates, and Dr. Wells informed me recently that we're the 6th highest enrolling center and recently completed enrollment of our first 500 patients into our registry here. So I want to thank all of you for listening, and thanks especially to Dr. Laleko, Dr. Wells, and Dr. Mehta, who gave me some really helpful input on this topic. And I will take any questions.
Thank you, Maya. Very good review. I actually just have a quick, interesting patient. I have a woman that I see in clinic who was traveling out in Arizona, I believe, a few years ago, and had spontaneous dissection of her RCA and was treated out there medically. And so she'd been sort of following with me, otherwise very healthy, maybe 70-ish-year-old woman, and then was admitted to St. Joseph's Hospital a week or two ago with recurrent chest pain. This is 3 years probably after her index event, and ended up having Takotsubo with a normal coronary CTA. She had been, I think, a stressful event with her daughter had just occurred, and had a very mild elevation in troponin with chest pain, and CTA was normal essentially, and echo consistent with Takotsubo. So clearly, as you mentioned, that microvascular sort of dysfunction sort of maybe a predisposing, either whether it's a predisposing or something that results from one of these events, seems to be part of the milieu.
Yeah, that's an
Yes.
interesting case.
I was going to say I guess my question is more for long-term management, the role of statins and or aspirin long-term in these patients.
I think so. In terms of statins, it sounds like there was mixed data in the past, but most recently, it doesn't look like statins actually help reduce risk of recurrence. So currently, the recommendations are to use statins for primary prevention of atherosclerosis, but otherwise, just because of the history of SCAD itself, that shouldn't be a reason to put patients on statins. But of course, if they have an elevated LDL and you're doing this for primary prevention of atherosclerosis, it does make sense, I think, to put them on.
Maya, this is Peter Block. Can you hear me?
Hi, Dr. Block, I can hear you.
Great. Lovely review. I just wonder whether any of these patients or a group of these patients has ever been genetically tested. I mean, clearly this is some kind of a genetic abnormality, which is associated with other bad stuff that happens during their lives. But nonetheless, is there any data, or are there any data, to substantiate whether or not you can predict this in patients?
So that's a great question. They actually have had some studies where they tried to identify like a monogenic locus for SCAD, but they have identified a few genes that have been associated, but it's quite, there isn't a clear familial connection. So they haven't really, they've identified a few different genes that may be involved, but the data is not really robust enough to advocate for genetic testing in all of those patients. So I think there's still a lot more to be done, but hopefully with these large registries of patients and having just more volume for studies, I think that might be more helpful in hopefully finding some genetic predictors in the future. I hope that answers your question, Dr. Block.
Yep, thank you. I appreciate that.
Mm-hmm.
I can make another comment if you'd like, while everybody is thinking about if they want to ask another question.
Sure.
I actually have familial experience with this, and a niece around the corner who was 42 when she had a spontaneous dissection of her circumflex marginal. Interestingly, she did well with conservative therapy, and the docs taking care of her recognized it.
Mm-hmm.
3 weeks after her dissection, when she was home, she fainted, quote unquote. And when they Holter monitored her, she had bouts of ventricular tachycardia, for which she now lives with a defibrillator. And just to point out that myocardial infarction is still myocardial infarction, and you can't forget that there are other bad things that happen to people down the road after they have myocardial scar.
Thank you. That's a great point.
Maya, that was a great talk. Thank you. I'll just make a comment that, whenever you're out in practice and you get referrals for somebody who had a troponin elevation at an outside hospital, they had a cath was okay, and they're coming to you for a second opinion. Really important to request that actual angiogram and review it with your interventionalist, because they're often missed. They're subtle cases and then they're missed. So, I've had several patients where I specifically patiently waited for that angiogram to show up because that's always a pain where, you kind of look at the report, but you really have to look at the actual angiogram with your interventionalist.
Mm-hmm. Good point.
And I was going to say also, there's no telling how many of these like type 3 patients are walking around, with just carrying the diagnosis of run-of-the-mill coronary atherosclerotic heart disease, when in fact it was probably, possibly a little focal dissection is probably something that's very, very difficult to quantify. Okay, well, thank you everyone for tuning in this Friday morning. Have a great weekend, and thanks again, Maya.
Thank you, everyone.
The preceding program is copyrighted by Emory University.